So the next talk is by Dr. Francesco Pichi, an OCT journey from histological to microscopic visualization.
Now I'm scared because I'm going to talk about histologics. Hey, I have 10 minutes. 10 minutes. It's okay, I'm kidding. Oops. Can I go? Yeah. Okay, so this is Google Maps of my hometown. You can see I was born in Italy, in the north of Italy, but you cannot see a lot. So this is how OCT started for all of us in uveitis. You could detect most of the complication of uveitis, CME and its treatment, choroidal neovascularization, and its improvement with the treatment. But it's like driving a Ferrari in a parking lot. So we were not using OCT at its full potential. Now zooming in, you know I was born around that area. You have some telltale cities here, some autoroutes, so you could find out where I was born. And this is where we took OCT next. We were looking for biomarkers of our disease. So in multifocal choroiditis, for example, with OCT, you can find some telltale signs that are telling you this could be multifocal choroiditis. For example, this hyperreflective material breaking through the RPE. And behind the material which is breaking through the RPE, there's usually this cone of hypertransmission. And when the material hasn't yet broken through the RPE, the cone is still there. Same thing happens, for example, in AMPI. We heard about AMPI, and OCT is giving them some sign. Choriocapillaris ischemia, this alteration of the RPE, and the edema of the outer nuclear layers. And of course, we heard a lot about all the OCT signs of VKH, this choroid thickness, loss of the vasculature, and the undulation. Now you zoom in, you know I was born in Bologna. Now you get a clearer idea. You can see my hometown. So we are going smaller and smaller with OCT. And there's a lot of papers published out that look at OCT compared with this histology and show how it corresponds very, very well. So for example, in viral retinitis, OCT shows a disruption of the retina with the lacunae, and this is reflected in histology. There's a full thickness retinitis reflected in histology as well. When you deal with toxo, we heard a beautiful talk on toxoplasmosis. On OCT, you have both the full thickness retinitis and the choroidal infiltration. So this could be probably granulomatous and secondary, but so this is probably a retinochoroiditis. Again, comparing OCT and histology in toxo, here you have your retinitis, full thickness, and here you have your choroidal granulomatous inflammation, so the choroid is affected as well. In TB or sarcoid granulomas, look how EDI corresponds very, very well to histology. You have, with EDI, you have choroidal granulomas that can be distinguished because of this halo behind. In every choroidal granuloma is hypo and has this hyper halo behind it, so it's easy to distinguish it from normal blood vessels of the choroid. We go to Candida, and again there's a perfect correspondence between histology and the OCT. So here you have the Candida trying to go through the retina into the vitreous, because Candida does this. Whether it comes from the choroid or from the retina doesn't matter, it always tries to go towards the vitreous. Now, this is my neighborhood. Now you're seeing stuff in Google Maps that you can actually see with your own eyes. And that's the next step of OCT. We are seeing stuff that we can see with our own eyes and a slit lamp. So we've been using OCT, for example, to visualize keratic precipitates. Keratic precipitates are not part of sun classification, but it's something we look at all the time. And if we use anterior segment of CT, we are actually able to define them, isolate them, and create an fast map of the keratic precipitates. And you can see, for example, in this patient, you see the keratic precipitates as baseline and all these dots on the ANFAS OCT, and you see how they improve with treatment both clinically and on OCT. You can also look at the cells in the anterior chamber. Now, this has been going on for some time. It was studied first in Kola Institute, then by the Milan group. So all these little dots that we see clinically, they can be highlighted also on OCT. And they have different size, so we could technically distinguish them based on their size. This can be polymorphous nucleates, this could be mononuclear cells. We recently, it's not published out yet, but this is courtesy of Alessandro Invernizzi, so they are looking at, through swept source OCT, at cells, anterior vitreous cells, which again, not highlighted by the sun, but the MUST has a clinical scale for those, and using image J, they are able to count them and prove that there's an improvement. This is their uveitis group. You see all these studded cells behind the lens, and these are the control patient, where there are a couple of cells. They may be just vitreous debris because they are usually bigger. And finally, this was started by Alistair ages ago, looking at the haze of the vitreous based on OCT. But we are actually able to look also at vitreous cells. We published recently on American Journal that on OCT we can actually isolate all these cells and actually measure the flare. So we went from just looking at the bubble of fluid to looking at very, very small cells. Now, this one is my terrace. So it's something that you are zooming in a lot. So this is the future of OCT. Dr. Vishali pointed it out. It's not something you're gonna apply in your clinic, but it's something useful for research. This is a macrophage. Macrophage and microglia, they're part of your retina. They stay inside the retina, and then they go to the surface of the retina. Now, there's three types of microglia. The resident one that grab the antigens and they present it, or macrophages as well that grab stuff from outside. You got your halocytes, that are keeping the transparency of the vitreous, and you have leukocytes, which are very important for us because if you have inflammation in the eye, the leukocytes are coming. Now, this is again the same macrophage that I showed you, and it's done with the electron microscopy. And this is a representation of the macrophages on the retina. You can see them moving around. You can see their little pseudopodic arm grabbing here and there, trying to clean your retina. Now, how was this picture taken? Was it taken with some fancy electron microscopy thingy? No, it was simply taken with an OCT. In particular, OCTA and unfast OCT. Now, these are all parameters of OCTA that we don't really use in clinic, but in the medical retina people that, as Dr. Vishali said, they're driving our research, they looked at these macrophages-like cells for some time. So how do they do it? Well, Vass was the first one that said that if you do one OCTA, it looks like this. But if you average 6, it looks much better, so you have a much better resolution. And same thing applies for the OCTA, but also for the unfast that you have next to it. And the unfast is usually of the inner retina, but if you just move the scan above, this is what you get. So all these little dots are the macrophages of your retina. So how do we know that these are actually macrophages? These are actually moving. So you have some uveitis, especially who stood in front of a machine for 8 hours, and you can see all my macrophages here moving. If you superimpose the OCTA, you see that they stay around the blood vessel. They scan an area of retina. They don't move too far. They make sure that area of retina is fine and clean. And if you zoom into one particular area, you can see how they're moving, the pseudopodic movement. This is my other eye. Again, here you can see that they are moving, but they don't roam around too much, and you can see their movement here with the little pseudopodic arms moving. So why is it useful? Because in uveitis, like this MS patient, you have a lot of macrophages at baseline when there's a lot of inflammation, and they decrease when the inflammation is less. Same for this idiopathic panuveitis. Lots of these macrophages in the beginning, and they decrease with time. Now, I thank you very much for your attention, and I want to highlight what Dr. Vishali said. The last part is for our research, is to better understand diseases and have better biomarkers in the future. Thank you very much.